Our final lecture for the Pediatric Neurology lecture series will be on neuromuscular topics. We'll start by talking about spinal muscular atrophy. This is a autosomal recessive condition, and it's the second most common lethal autosomal recessive disorder. Mutations in SMN1 cause types 1, 2, 3, and 4. It makes the survival motor neuron protein. If you have extra copies of SMN2 gene, it can modify the severity. So the more of these SMN2 genes you have, the better you do. And it also develops later in life if you have more copies of number 2. 98% of children with SMA have a mutation in SMN1, and mutation analysis has replaced EMG and muscle biopsy for making this diagnosis. So SMA type 1 is also known as Wernicke-Hoffmann disease. The onset is less than 6 months of age. The best that these kids typically do is sitting, but that's for a very small minority. Most of them are not sitters. Mortality is for greater than 90%, with few surviving to the second decade. Typically, death is going to occur from respiratory failure by age 2. Clinical picture for SMA type 1 will be a child with symmetrical muscle weakness in a frog leg position with a paucity of proximal movement, with low muscle tone. They have a narrow thorax with a pectus excavatum, flaring of the lower ribs with a bell-shaped chest. They have weakness of the upper cranial nerves is rare, but weakness of the lower cranial nerves is common. Their CK is usually normal. That's a creatine kinase. Type 2 typically have normal milestones up to about 6 to 12 months of age. Their lower extremities are more involved than their upper extremities, with failure to walk typically being the chief complaint. The weakness can become static for long periods of time. They typically cannot stand or walk unaided, and their CK is usually normal as well. Type 3 is called Kugelberg-Wieslander syndrome, with an onset about 18 months to 17 years of age. They usually are walkers, but they may need assistance later in life. Most have a normal life expectancy. Clinical picture, they usually present with proximal muscular atrophy, a waddling gait, and their CK may be elevated. They have a lumbar lordosis, genu recurvatum. Reflexes may or not be elicited, but they're never hyperactive. And if they have an onset before age 2, they're usually going to stop walking by age 15. Type 4, the onset is typically after age 30. The symptoms are mild to moderate weakness, tremor, and breathing difficulty, and typically affects only the proximal muscles. We're now going to move to infantile botulism. This occurs year-round with a peak incidence in October and November, with a higher incidence in California, Utah, and Pennsylvania. Most common age is 6 weeks to 9 months. 90% are less than 6 months. They have a symmetrical descending paralysis. The clinical picture is generalized weakness and hypotonia with poor feeding and constipation, absent reflexes, a facial diplegia, ptosis, dry mouth with no drooling, and a poor pupillary response to light. The pathophysiology occurs from release of toxin in the intestinal tract by Clostridium botulinum. The toxin affects the presynaptic mechanisms that release acetylcholine. You can diagnose via stool culture. The treatment is put them in the ICU to observe for respiratory failure, support them, and avoid aminoglycosides. We're going to move on and talk about muscular dystrophy. Duchenne's muscular dystrophy is the most common, X-linked recessive pattern. Mutations of the DMD gene alter the structure of dystrophin. 1 in 3,000 males are affected. The onset occurs after 2 years of age with normal initial development, but then develop progressive weakness. Clinical signs include a Gowers sign, which you can see over here to the right. This child is trying to get up from the floor, but they're weak, and so they have to essentially walk themselves up their legs to be able to stand up. They have pseudo-hypertrophy of their calves, where their calves look big, but it's really just fatty deposit that's causing them to look big. And their CK is greater than 10,000 times normal. Here's a picture of the pseudo-hypertrophy of the calves. Becker's muscular dystrophy is an allelic milder form of Duchenne's. The onset is usually after 7 years of age. Ambulation is preserved beyond 15 years, and the CK is usually less than 20,000. Diagnosis for these muscular dystrophies is by CK. You can do a muscle biopsy, but nowadays most of these kids are being diagnosed by genetic testing for deletions in the dystrophin gene. Treatment is a multidisciplinary approach with referrals to cardiology, pulmonology, orthopedics, physical therapy, sleep medicine, and of course neurology. Steroids have been shown to help as well. You can use prednisone, but more commonly we're using deflazacort, which is an anti-inflammatory immunosuppressive derivative of prednisone with less weight gain, less diabetes producing effects, less osteoporosis, and less behavior problems. These are usually started around 5 to 7 years of age when they're having more trouble going upstairs, they're falling more, and having more difficulty getting up off the floor. And it's important to remember to supplement with vitamin D and calcium. Next, we're going to discuss Pompe disease, also known as acid maltase deficiency, glycogen storage disease type 2, or acid alpha glucosidase deficiency. It's autosomal recessive on chromosome 17, and there are two main types, the infantile onset and the late onset. The infantile onset has less than 1% of normal enzyme activity. It presents in the first days to weeks of life with a cardiomyopathy and feeding problems, cardiac arrhythmias, increased CK, increased LFTs, which is really due to the increased muscle enzyme, hypotonia, and weakness. Without treatment, they usually die before 2 years of age, and their heart is very big on the chest x-ray. So if they show you a chest x-ray like this and describes a weak child, it's typically going to be Pompe disease. The late onset occurs when you have 1 to 40% of the enzyme activity, and this can onset between late childhood to the 6th decade of life. They have less severe weakness, which usually affects the trunk and the proximal muscles, respiratory insufficiency, diaphragmatic weakness, ptosis, a rigid spine, lingual weakness, and vascular complications. Treatment, there is now an enzyme replacement therapy, which has been life-saving for these kids, and so you want to try to diagnose them as soon as possible to get that started. Next is MCARDLE disease, which is also known as myophosphorylase deficiency or glycogenosis type 5. Clinical picture involves exercise intolerance, which is for brief, intense isometric exercise, such as lifting heavy weights, or for less intense but sustained dynamic exercise, such as walking uphill. They have myalgias and cramps, premature fatigue, stiffness or weakness of muscles, myoglobinuria, and it improves with rest. They can have a second wind phenomenon where they get myalgias, but if they slow down or rest, they can then resume activity. It's autosomal recessive due to a mutation of muscle isozyme of phosphorylase, PYGM, on chromosome 11. Their resting CK is elevated, and the treatment is to adapt their lifestyle to their limited exercise tolerance. And if they do get periods of myoglobinuria, they need to have excessive fluid intake. And if it's really bad, they may need dialysis.